Welcome to AAOMPT Hands-On, Hands-Off podcast. My name is Leda McDaniel. I am a physical therapist and a fellow of AOMPT, and I have the extreme pleasure of speaking with Dr. Thomas Ibounig today, who is the primary author on a recent study that came out in 2026 in JAMA. That we will be talking about today, titled Incidental Rotator Cuff Abnormalities on Magnetic Resonance Imaging. Welcome, Thomas. Thanks so much for being with us today.
Pleasure to be here.
And just a brief introduction, Dr. Ibounig is a shoulder and elbow surgeon at Helsinki University Hospital, and he's also a part-time researcher at the Finnish Centre for Evidence-Based Orthopaedics. So he's joining us from Helsinki, so we're quite lucky. As we kind of kick off the conversation, I was wondering if you might just briefly describe your clinical and research background and some of your interests as a clinician and researcher.
Yeah, as you introduced, I'm a shoulder and elbow surgeon at the Helsinki University Hospital, and that of course involves clinical work and doing surgeries. But then I'm also very interested in research because I think it widens our perspective on things. And then on the other hand, the clinical work keeps us grounded and then connected to the patients. So I really like that setup, that it's part-time research and part-time clinical work.
That's excellent. And could you speak to a little bit of your kind of inspirations or research interests that led you into this particular study and some of your other work?
Well, by nature, I always like to understand what I'm doing before I'm doing it. So I'm very, very much into not only treating and treatment outcomes, but what we are treating, why we are treating it, what's behind the rationale of our treatments. And I think that during my specialization, I was always looking at studies and treatments, and I found somehow there was a dissonance between what we are doing and treating and what we know about imaging findings, how common abnormal imaging findings are in other joints. For example, a very important study for me was the study on meniscal tears published in NAME in 2008. So that really opened my mind or my eyes, because I was scoping a lot of knees and resecting meniscus, and the patients came to our outpatient department after 3 months, and they were really happy with the knee, and so it was kind of hard to understand why we shouldn't be doing that. But then when I saw the study that actually those meniscal tears are as common in people without pain as in patients, then I really started to think that something is not fitting into that picture and something isn't right. And are we treating the right things, or is there something else involved? So that's how I started to dig into that subject.
Yeah, that's great background. I think that's really interesting as well. So that kind of leads us naturally into the study that we're here to discuss with you today. So would you mind kind of giving us the background of the motivation for this particular study and how you got such a large study off the ground like this? By my last count, there were 18 authors on this study, and it's quite an undertaking. So the study that we're referring to, if you're just jumping in with us, is the recent JAMA study from 2026, Incidental Rotator Cuff Abnormalities on Magnetic Resonance Imaging.
Yeah, so as I'm a shoulder and elbow surgeon, I wanted to see or to find out or get a better picture on how, and because of course, as a surgeon, we are very much into fixing things. We like to look at structures, identify structures, find out what's broken, and then we start fixing it. So very, very much into that, and too little into other things probably. But so then I wanted to see, well, how does the shoulder look like? What's normal? What's abnormal? Before we start treating something as abnormal, we first need to have a baseline on what's normal and what's not normal. And so I was and we have, of course, some studies showing us that some of those changes we are treating are actually quite common in people without pain, but then some representative large studies from the general population, we were actually lacking at that point, and that was the reason why we planned this study. And as you said, it's quite a large study, and we have 18 authors, but this study is based on the Health 2000 survey that was performed in Finland. That was much bigger. So there were like hundreds of doctors involved all over Finland in doing the Health 2000 study, and setting up that large study with just a couple of or 10 to 15 people was actually quite an undertaking, and it took us a long time, over 10 years, to plan, get funding, get everything set up before we could get rolling.
Yeah, absolutely. So you did mention that the sample was kind of a subsample from this broader Health 2000 study. Getting into the study design for your particular study on MRI in shoulder, for shoulders, can you talk about the sampling process and selection and how you chose the population to get in touch with and screen and things like that for your particular study?
Yeah, so that was one of the questions right from the start. Do we want to base our sample on an already existing sample, or do we want to draw a completely new sample from the general population? And of course, now we are orthopedic surgeons, or my research group was mainly consisting of orthopedic surgeons, so we don't have a lot of expertise into that. But luckily, we got in contact with the National Institute of Health and Welfare and epidemiologists that helped us think about those questions, and we decided to go with a previous sample, because one thing that we have not yet published, but that we want to look at is also longitudinal aspects. Like we have from the Health 2000 study a lot of things collected in the year 2000, risk factors, lifestyle, blood samples, working history, that we intend to analyze and look at how do these things affect both shoulder symptoms but also imaging findings in the long term. So that was one reason why we wanted to use that old sample. And the other reason was that we know that nowadays general health surveys have a participation rate of around 50 if we are good at it. And that, of course, always leads to a selection bias. And then you cannot be completely sure how representative your population in the end is. But using the Health 2000 study that had a participation rate of 89%, made us able that, although in our sub-study we did not reach that 89% of participation rate, but we knew what would have been a representative sample, and we could control for it and also make statistical adjustments so that in our final results we got a representative sample of the general Finnish population.
Yeah, that's great. That was definitely clear in how you described it in the paper, and thanks for explaining that for our audience. I think that's an important point, that you were doing the best you could to make sure that it was representative. So describe for us a little bit about what you did in this study and what you all found.
So then coming back to being representative, of course we had to make some cutoffs. So we wanted to have a modern imaging 3 Tesla MRI pictures, and they were not available, of course, all over Finland in smaller villages. So we had to cut some corners and restrict our sample to the 5 university hospital districts. But actually, the majority of the Finnish population lives within those areas. So that was one of our main things that we based our study on: the 5 university hospital districts, 3 Tesla MRI imaging of both shoulders, and then also a thorough clinical examination by shoulder surgeons, and then also a variety of questionnaires assessing basic health parameters, lifestyle risk factors, and then also shoulder-specific and work-specific questions. Also, a lot of psychological questions on pain catastrophizing, pain self-efficacy, anxiety and depression, and stuff like that.
Great. And so putting all this data together, what are your takeaways from the study? Can you describe a little bit about how you analyzed the data? And there was some discussion of different regression models within the paper, but I'm curious your insight into the choices for the 3 different regression models that were described and how you tried to make sense of the potential relationships between, as you described, not only the imaging findings, but quite a comprehensive clinical battery of tests, which to your credit, we think about a lot as orthopedic manual physical therapists of utilizing imaging as not a standalone finding, but as part of our information that we analyze in conjunction with quite a thorough clinical exam. We kind of pride ourselves on that. So how do you do that from a research standpoint, factoring in all of those different variables to try to make sense of it?
Yeah, that's a good question. Of course, not an easy question to tackle, because there are many different ways, and probably none of those ways are completely perfect. But so I think that what we achieved with our sample was that we got a very good certainty on the prevalence of those imaging findings in asymptomatic and symptomatic shoulders. But then, of course, those imaging findings and symptoms, they could be caused, for example, looking at the shoulder, also by other structures, not only the rotator cuff. So how do you want to make sure that not osteoarthritis of the shoulder or AC joint problem, biceps problems are the cause of symptoms? So the first adjustment that we performed, in addition to an adjustment according to age, sex, region, and education, which would be general risk factors or factors affecting prevalence. So we looked at other imaging findings and adjusted for those, and we saw that the difference in prevalence between symptomatic and asymptomatic shoulders was reduced a little bit regarding full thickness rotator cuff tears. So when the difference in prevalence in our base sample was 8.1%, 6.5% in asymptomatic shoulders, and 14.6% in symptomatic shoulders, then after adjusting for these other imaging abnormalities, the prevalence difference was reduced to 6.7%, so a little bit reduced. And then we thought, okay, well, no one is treating, or at least no surgeon admits that he or she is treating only based on imaging findings alone. So of course we have the clinical examination playing a very big role into that. So we also wanted to look, well, how does clinical examination findings, if we use those, we should be able to better identify those with symptoms and those with no symptoms, symptomatic rotator cuff tears. And we were really surprised, or we were on one hand surprised, and then on the other hand not surprised, that actually the difference diminished completely, and we didn't get any improvement in our diagnostics using these clinical tests. And I think that's also, I think that orthopedic surgeons are not good at or very structural orientated, but from my experience, although physiotherapists are much better in accepting the fact that pain or symptoms are not only based on structural problems, I think where physical therapists also are a little bit biased probably is those clinical maneuvers and clinical examination. We're very fond and proud of all our maneuvers that we have, and we are really, especially when we are really experienced, very much able to identify with certain maneuvers the cause of pain and symptoms. But then when we look at the literature, actually, first of all, I think that also regarding clinical examination, we have some lack of good studies, but those studies that we have actually show that our isolated clinical examination maneuvers are like the flip of a coin mostly. So they also don't seem to help us on their own as much as we would think. And then I think it's putting all those things together, and that's really difficult to at least at the moment. I think that AI might help us in this, but putting all those small pieces of the puzzle together and doing research on that is really difficult. So although single maneuvers or a single image might not be able to show us the cause of pain, at least with a very high certainty, putting all those stuff together might help us a little bit more. In our model, it did not work out, and I don't think that single maneuvers are very good or single imaging. But then there might be some things, and maybe it's even more patient history or patient baseline characteristics that play a bigger role in showing us what's the cause of symptoms in each individual patients. Because I think that it probably depends a lot on the person where the pain comes from.
Yeah, I think those are great insights. And I think you're right that we tend to have some bias to think that our clinical examination findings are a little bit more robust or allow us to diagnose, but we need to take the same research-based lens to those tests as we do to a standalone imaging finding. So just to come back to what you were describing, and if I'm understanding correctly, what you're basically saying is the addition of those clinical examination tests did not improve the ability to use imaging to detect asymptomatic rotator cuff tear. Is that what you're describing from the study findings? And then can you talk a little bit more about just one of the big findings that we've kind of danced around, but the high prevalence of asymptomatic pathology that showed up on imaging?
Yeah, so exactly. So using and we did a really thorough battery of clinical tests. So we used basically all commonly used rotator cuff tests, both pain provocation tests and then also only functional tests measuring strength and lag signs. And we looked at both of these, both pain provocation and strength or functional measurements also separately, because we wanted to see, well, maybe pain does not tell us as much, but maybe those functional impairments help us to identify those symptomatic tears better. But it did not help us, and of course one explanation for that could be that the majority of full thickness rotator cuff tears that we found were quite small, small supraspinatus tears, where you probably would not expect a large strength deficit or functional impairment. And then again, pain, if we're just looking at pain, then a small rotator cuff tear or no tear could be as painful, the shoulder. So maybe it's related to that, but still it just shows that there is a lot of uncertainty both around imaging and those clinical tests that needs further investigations. But yeah, as you said, that one of our findings, or the most important finding, was that basically every shoulder over the age of 40 had some abnormalities on the scan, 99% altogether. Of course, here we also have to again look at what kind of abnormality we're talking about. So majority of these abnormalities in younger age groups were tendinopathy and then partial thickness tears. But then as age increased, we didn't find, for example, any full thickness tear in 40-year-olds, but over the age of 45, those full thickness tears started to appear, and then over the age of 70, they were already over 20% in cases. And yeah, so what was also surprising was that there was actually quite a high percentage of partial thickness tears. In our overall sample, they were over 60% of those partial thickness tears, and and there was no difference at all between symptomatic and asymptomatic shoulders regarding those partial thickness tears.
Yeah, it's quite profound, just the high percentage and some of the graphics in the article, how many individuals have shoulder pathology on imaging that are asymptomatic. So I think that's quite important to our overall research base. So commend you all for adding that to what we know about this issue. I guess my next question would be to kind of describe how you think that this fits into our broader understanding of shoulder pain, how we diagnose shoulder pain, how we treat it. You alluded to the fact early on as a surgeon, it kind of changes maybe some of your treatment choices. Can you speak to that after doing this specific study? And you mentioned the meniscus study, but now that you have been a part of this research and have seen what goes on in shoulders potentially in this sample, how does this inform your clinical practice, and what are your recommendations for our broader orthopedic community?
Well, not only this study, but overall, the older I get and the more experience I get, the less sure I am what I'm actually doing. So as a young doctor, fresh from med school, you quite soon get to a point where you think you know everything and you understand everything, and that's how you should be doing it. And the more I look into this and the more I think about it, the less sure I'm. I don't think that at the moment we are, and I'm not talking about trauma and fractures and real injuries, but all those non-traumatic pain problems that we have. I'm not sure that we know at all what we are doing. So and all our, or the majority of research is focused on just comparing different treatment methods or looking at new methods to treat. But I think that we should just put more effort first into understanding where does pain come from, what's the reason of pain, how do we identify the cause of pain in each individual patients, because I'm sure that there are some rotator cuff tears, for example, that are the cause of symptoms, and then there is so many of those that don't explain the symptoms. But how do we identify the right ones and then target the right treatment at those patients? I don't think that we have the answer yet. Our study, I think, provides some answers, but it even poses more questions on unsolved issues that we first need to understand that we know too little, and then in the next step focus more on those basic studies to help us improve our understanding on pain pathologies.
Yeah, well said. So if you were to give advice to our clinicians out there, whether those are medical doctors in orthopedics or a lot of our audience are physiotherapists in orthopedics or OMPT related practices, what would you say are the clinical takeaways from a study like this, and how could it inform our clinical care to be more evidence-based?
So one takeaway is that imaging findings or then abnormal clinical examination findings are very common, and both in symptomatic and asymptomatic persons, and we should before we too quickly target or well, let's start that one new. I think that terminology is extremely important. So what we find and how we translate those findings to the patients is extremely important. We can cause a lot of damage. For example, if we have an imaging finding and we know that 99% of persons will have that imaging finding, and then we tell a patient, you have a tear or you have something that is broken in your shoulder, you make a healthy person into a patient or a sick person. So we really have to think how we frame our findings, and looking at certain age group. What is not normal in a 20-year-old is completely normal in a 50-year-old. So we have to adjust our interpretation of findings according to that, and also then translate those findings in the right way to the patients. Not saying something is broken, but some actually what we see is completely normal. It's a little bit of wear, like your beard is gray or your hair is gray. Your shoulder looks the same, nothing to worry about. Taking away the worry, um, um, giving the patient some trust that everything is going to be all right. They're not going to die. Their pain will get better, probably no matter what we do. I'm a strong believer in physiotherapy and exercise treatment, but I would say that also that needs some further evaluation, how beneficial it is, and how often patients would get better on their own, or just get better by the fact that they know there is nothing to worry about. Keep on doing what you're doing. You don't have to be afraid that you're damaging your shoulder if you're doing too much or this or that. But then also being maybe um, getting the patients to understand that what you have been doing as a 20-year-old might not be any more possible as a 60-year-old, and that doesn't mean that something is broken or abnormal. It's just some facts that we have to accept and modify.
Yeah, well said. I agree with that. Do you think that this has changed your own clinical practice and how often you're recommending and performing surgeries or your work with colleagues in your hospital care setting?
Well, we have been always very critical in our study group and in our working environment. So already when our research group is also very much into doing placebo-controlled trials, and taking those findings into clinical practice. So we have been also always very trying to make sure that we are not treating too much. Of course, it helps in a public healthcare setting where your salary is not depending on the amount of surgeries you do. It probably helps a little bit, but so I wouldn't say that this specific study has changed the way we are treating patients at our hospital. We have always been very critical, uh, uh, but for sure it has put even more effort into research that helps us find those reasons for pain. If the structural finding is not the explanation, then we have to look what else could be the explanation.
Absolutely. Speaking to that, do you have further research that you are participating in currently that may help to inform some of this broader understanding of pain mechanisms as applied to this population or the integration of an evaluation of potentially pain mechanisms within this context? And I know that just adds more data collection and complexity to a study like this, but if we think about reconciling the imaging findings with the clinical exam, and that didn't quite provide the insight that maybe one might expect as a clinician, then you're talking about taking a look from more of a broad nervous system perspective, which we definitely do in OMPT education and practice. How might that look from a research setting, or do you have ideas on how you might apply that in the future?
Well, I mean, basically the whole, as we already were suspecting that maybe the imaging is not a very good explanation for many symptoms, we try to also assess in our study a lot of those other possible explanations, the psychological parts, the um, work strain and metabolic reasons. So we assessed all of those facts, and not only in the year 2023, but also in the year 2000 and 2011. So we have data from 3 time points. We are planning on using that data from the Health 2000 study and our data and see what parameters in the year 2000 or 2011 could explain symptoms or imaging findings or a combination of those, and hopefully we get a better picture. So basically, part of the FIMAGE study research now that the structural things are analyzed. Our next big part will be looking at those other potential explanations for symptoms.
Great. Well, we have some things to look forward to as far as research coming from your group. Anything else that you want to leave our listeners with in describing this study, or clinical pearls just for our physical therapy audience, orthopedic audience?
Well, I think that physiotherapists are much better in treating patients than many surgeons. So maybe it's the other way around, that we surgeons should listen more to you guys on what we should be doing.
Well, I appreciate that. That's quite the compliment. Dr. Ibounig, thank you so much for your time and sharing your research and clinical insight with us today. And best of luck in the future. We'll definitely be following you.
Thanks a lot.
Thanks for listening to Hands On, Hands Off, the official podcast of AOMT. Subscribe now so you never miss an episode, and connect with us at aomt.org or at AOMT on social. Opinions are those of the guests and not official AOMT policy. See you next time.